Well, welcome everyone. Thanks so much for joining In the Hot Seat, a live Q&A on all things retina, brought to you exclusively by Astellas. And so this is your time to ask anything that's been on your mind. Just drop your questions in the group chat here during the session, and I'll try to answer as many as I possibly can throughout this half-hour session. And we've got some fantastic questions that we've already received ahead of time. So I'm going to mix those in kind of as we go. So make sure you keep those questions coming in. So our first question that came in through an email prompt was from Alan, and he asked, what are the little white dots in the peripheral retina that look like snow? And I think probably what this is referring to is Gunn's dots. So these are like visible reflections of the internal limiting membrane that are commonly attributed to the reflectance of Mueller cell like foot plates. I would also consider if it's something where you're seeing like little whitish flecks, almost like snowflakes, inferior temporal in both eyes, that could be areas of potentially retinoschisis. So that would be another consideration. And of course, patients also can potentially have just like peripheral drusen, although those are usually a little bit more yellowish in hue and more deeper down in the retina. So Gunn's dots are going to be more superficial because it's the internal limiting membrane, whereas drusen are going to be deeper down underneath like the larger blood vessels in the superficial retina. So thank you so much for that question, Alan. Just trying to see if anything else has come in. Our next question, there's actually sort of two people submitted questions that were very similar, so I'm going to read both of them. What is your opinion about a retinal hole? In the state where I currently practice, retina specialists don't treat them, but I practice in other states where they are treating them, saying it's better to be on the safer side. And then another question was retinal hole without subretinal fluid, to treat or to observe? I guess that is the question. So I think there are a lot of things to consider here. And I've prepared a few like slides and pictures here if we could share throughout this discussion. And so I think the first thing is to consider just general break features that would be high risk for progression to regumatogenous retinal detachment. And so I think when we're looking with our clinical assessment or we're looking with OCT, we want to ask, what is the extent of subretinal fluid cuff? Is there a subretinal fluid cuff? And then we want to ask too, is there vitreoretinal traction on the margin of the lesion? So, or the break. And so either of those features would be higher risk for progression to regumatogenous retinal detachment. You know, if there is traction on the edge of a break, like let's say a flap tear, that's going to increase the risk for progression to regumatogenous retinal detachment, because when there's motion, right? So when the eye moves, the vitreous is attached to the flap of that tear, and it's going to consistently pull and promote fluid from flowing in through that tear and accumulating in the subretinal space. And so vitreoretinal traction is a very important consideration when it comes to saying, is this something that I need to refer or can I hold in-house? Here's an example of a patient with a hole that's particularly low risk that I did refer to retina, but we are just monitoring at this time. So where there's no subretinal fluid cuff, there's no vitreous attachment to the edge of that break. I think what else this highlights too is the utility of like ultra wide field imaging and off-axis OCT so that you can get a good sense of when you're seeing a peripheral break, is there a cuff of subretinal fluid? Is there vitreoretinal attachment? And if you don't have access to OCT or off-axis OCT, consider doing like scleral indentation to, again, just try to get a sense of, is there any vitreous attachment or fluid around that break? Also important to consider are risk factors for regumatogenous retinal detachment. And so risk factors that would be, potentially a concern, it depends on the clinical case as a whole. But if there are, the patient is a high myope is something to consider. Is there a history of trauma? Trauma-related breaks should really always be referred to retina specialists for consideration of barrier laser. Is there any history of intraocular surgery, like cataract surgery, ND YAG laser, YAG capsulotomy surgery? Is there a history of regumatogenous retinal detachment in the other eye, or a family history of a regumatogenous retinal detachment in a first-degree relative? Then we also know there's certain genetic disorders like Stickler syndrome that also increase the risk of developing rhegmatogenous retinal detachment. So then you're kind of asking yourself how many risk factors are stacked against this individual when you're trying to determine, is this something I need to refer or not? I pulled this table from the American Academy of Ophthalmology preferred practice patterns for posterior vitreous detachment, retinal breaks, and lattice degeneration from 2024. And I love this table because it's a nice summary of what is the lesion and then what do you need to do with it in terms of potential referral to a retina specialist. Would it maybe be treated? And so what we can see here is that patients with acute horseshoe retinal tears or traumatic breaks usually require treatment. And I would encourage you to refer any flap tear, even if it looks chronic, they may not treat it, but a flap tear we know is under vitreoretinal traction, and I think that's important to refer. Of note here, if we look at patients, this is asymptomatic atrophic or operculated retinal tears. So I think this is part of where the question came from. An asymptomatic atrophic break rarely need treatment. More generally, an eye that has atrophic round holes within lattice lesions, minimal subretinal fluid without progression, or lacks evidence of a posterior vitreous detachment does not require treatment. And so I think that's really the summary take-home answer of this case right here. And I want to talk about different types of breaks in lattice. So we were talking about atrophic holes, and typically atrophic holes within lattice can be observed in-house, don't require a referral to retina unless there's a ton of risk factors like we just discussed. But there's another type of break that can occur in lattice, which is a flap tear at the time of posterior vitreous detachment. And a flap tear is due to the tight adhesion of the vitreous on the margin of lattice lesions, and it can pull and cause a flap tear. And that's something you would definitely want to refer to retina promptly for consideration of prophylactic barrier laser. But atrophic holes are relatively low risk and can be monitored in-house. Great. And let me look at some of our other questions here. Is decaf coffee as beneficial as regular coffee for diabetic retinopathy? I don't know the exact answer to that, but I will try to get an answer and put it into the next the hot seat Q&A session here coming up later on today. Is there a way to diagnose an old attack of retinal vasculitis after resolution? And so, retinal vasculitis often leaves behind it some clinical features that would, let you know that there's been some insult to the vasculature. So like sheathing, when we have whitening of the vessels in the fundus, that's kind of indicating to you that there's either an ischemic issue going on or an inflammatory issue going on. And so typically retinal vasculitis would leave behind some retinal vascular sheathing. Another example to kind of like think about and put this in perspective too would be, think about like active ocular toxoplasmosis infection, where you have that sort of characteristic like headlight in the fog appearance, a whole lot of vitritis, but also typically a local focus of chorioretinitis. Often what comes with that is also retinal vasculitis. So you'll often see patients with these old like toxo scars that have had, chorioretinitis and vasculitis in the past, but you'll also see areas of vascular sheathing potentially as well in patients with toxoplasmosis. So I would look for vascular sheathing as a potential outcome of past retinal vasculitis. And if you have access to OCT angiography, that's probably going to show you some vascular damage as well as probably some retinal non-perfusion, because most causes of vasculitis cause occlusion of the vessel as well and would result in some sort of retinal non-perfusion that you could visualize with angiography. Besides not being able to compare A1C to time in range, ability to continuously monitor a diabetes patient's glucose levels, what are some other reasons why time in range is now chosen over A1C, and why not use them both? I do think both are important to consider, but time in range gives us a really valuable perspective on the variability of glycemic control versus the A1C is just an average, right? So like, let's imagine we have two patients, both with hemoglobin A1Cs of like 6%. We're thinking, oh, that's pretty good. One patient is pretty like consistently at the same glucose level versus the other one fluctuates up, down, up, down, up, down, but they have the same average. It's much like glaucoma, right? So you could have two patients with the same mean intraocular pressure. If one is like really stable, that's going to be less damaging to the optic nerve head versus say a patient that has these large fluctuations in intraocular pressure where it's like it spikes at night and then goes down during the day, etc. And so it's that variability that really causes damage, we think, to the blood vessels with glycemic index in patients with diabetic retinopathy. And, you know, in terms of glaucoma, that variability in IOP also causes more extensive damage than if you're stable as well. And so if you do have a patient that has continuous glucose monitor, I think asking them about time and range is very important. But, you know, also knowing that average like A1C is also of value. Someone asked, can you link, Dr. Lee, can you link to the chart regarding referrals for retinal lesions? Like if you just open your web browser and type in American Academy of Ophthalmology preferred practice pattern for posterior vitreous detachment retinal breaks, it'll pop right up. It's available online, and it's like a PDF document that you can download and access, which is really valuable. Oh, thank you, Dr. Gerson, for answering the question about decaf versus regular coffee and the benefits. He said studies have shown benefits of both decaf and regular coffee. Thank you so much, Dr. Gerson. Oh, this is a great question. I think it kind of ties into one I have coming maybe a little bit later on. I'm going to table this for just a minute. So another question, let's jump back to some of the questions that came in through the email here initially. One of them was how do you treat cystoid macular edema based on OCT? And so I think OCT provides a lot of value when you're trying to determine what is the classification of diabetic macular edema. And so we've really shifted away from the terms of like clinically significant diabetic macular edema, and we're now saying, is it center involved or non-center involved? And certainly for me, if it's center involved diabetic macular edema, even if there's good vision, I'm going to consider referring that to a retina specialist. If there's decreased vision with center-involved diabetic macular edema, you should definitely refer that to a retina specialist for consideration of anti-VEGF therapy. I just want to pause for a moment and talk about the visual here. So center-involved diabetic macular edema involves thickening within the central subfield zone on your ETDRS-like grid, which is present on almost all OCT printouts. So if you have thickening there within the central 1 millimeter, we consider that center-involved diabetic macular edema. I would encourage you to refer that patient to a retina specialist for consideration of treatment if they're not already undergoing some sort of therapy. Here are some examples of patients with center-involved diabetic macular edema. We can see in this patient over on the left, it's a little bit more mild, but there is a cyst intraretinal fluid cyst right in the center of the fovea. Our central subfield zone here is pink, meaning it's thick to the 1% level of significance. And then over on the right-hand side, we have severe center-involved, like rather diffuse center-involved diabetic macular edema. Definitely would be treated by almost all retinal specialists with anti-VEGF therapy in this particular case. So I think, you know, the answer to how we treat macular edema using OCT, and it really depends on the etiology, right? So if we look at patients with diabetes and diabetic macular edema, typically that's anti-VEGF first line, although like focal or grid macular photocoagulation may be used in some rare cases where there's like extra or non-center involved macular edema that we're able to identify like a point source of leakage and just kind of really focally laser that particular entity. But really the mainstay of initial therapy options for diabetic macular edema is going to be anti-VEGF agents. And I'd say most retina specialists are treating patients that have center-involved diabetic macular edema, especially if they have a decline in vision. And I know a lot of retina specialists are kind of following the protocol V of the DR cro.net. And so this Protocol V study, they looked at patients with center-involved edema and had good vision and said, should we treat them? Should we not treat them? What's the natural prognosis for these patients? And so what they found is that patients that had relatively good vision, where they deferred, so vision of 20/50 or better, and then deferred treatment until the visual acuity was 20/30 or worse, fared pretty much just as well as patients where they treated from the get-go. And so sometimes you may have a retina specialist wait until the vision declines to treat center-involved diabetic macular edema. But I don't think, that's really our call to make as optometrists. I think we should be referring all patients with center-involved edema for consideration of anti-VEGF therapy. And then certainly, you can get macular edema from other causes. So like retinal venous occlusive disease, and regardless of whether it's central or branch, your first line therapy is going to be anti-VEGF injections. Other therapies that would be considered potentially also may be like intravitreal injection or sustained release steroid. Post-pseudophakia, or like what used to be called like Irvine gas syndrome, is another cause of macular edema, in which case we would typically treat that initially with topical NSAIDs and steroids about 4 times a day. There's also uveitic macular edema. So if patients have like chronic, now I've seen it even in like chronic anterior uveitis, but especially like intermediate uveitis, you can get macular edema and a little bit of disc edema associated with that. And so in that case, we're treating that with topical steroids, topical cycloplegia. If that is ineffective, you may want to consider like a steroid subconjunctival or subtenons, or potentially intravitreal steroids too. So it kind of like depends on the case and whether it's anterior uveitis or intermediate uveitis. But some sort of steroid and cyclo there hopefully can get the job done. You can also get macular edema from inherited retinal diseases. If we think about like retinitis pigmentosa, and typically that cystoid macular edema is treated with topical carbonic anhydrase inhibitors. And then of course, like medication toxicities and stuff too, with like anti-cancer medications, etc. And so that's really unique just depending on the etiology there. I want to move on to our next question. I think is a really important one that came in before the session here in the emails. And so patients with controlled diabetes, DFE annually versus Optos. And so I took this question to mean, what is the standard of care? Do we still need to dilate patients with diabetes when we're doing our diabetic eye examination? And so in order to answer that question, I want to reference the standard of care documents and like the most up-to-date version ones that we have. So the American Optometric Association standard of care documents are our clinical-based guidelines. And so they do have one here, and I've pulled some tables from it. Eye care of the patient with diabetes mellitus, second edition. And some of these consensus statements, I think, are very supportive of dilating patients. So this first consensus statement saying retinal examinations for diabetic retinopathy should be performed through a dilated pupil. It's sort of like point blank. And then the next consensus statement is regarding fundus photography for patients with diabetic retinopathy. And it says the evidence-based action statement, fundus photography or retinal imaging should be considered to identify diabetic retinopathy lesions and document retinal status. It's not intended to be a replacement of the dilated eye exam, but to augment the dilated eye exam. And I love my like ultra wide field color fundus photography. I think it helps me identify diabetic retinopathy lesions all the time that I miss on clinical examination. But I think it's important to recognize it as like a supplement to the dilated eye exam, not a replacement of, in order to make sure that you're within standard of care. Also in the AOA clinical practice guidelines, one of the other action-based statements that I thought applied here, it said the initial ocular examination of a person with diabetes should include all aspects of a comprehensive eye vision examination with ancillary testing as indicated to diagnose and thoroughly evaluate ocular complications of diabetes. And so I then went to they have a clinical practice guideline for like what is considered a comprehensive eye exam on patients or adult patients. And in that particular clinical practice guideline, it did say pharmacologic dilation of the pupil is generally required for a thorough stereoscopic evaluation of the ocular media, blah, 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 etc. And so I do think the benefits of dilating, as they're mentioning here, is the stereoscopic evaluation looking for changes of diabetic retinopathy that could be missed potentially on just color fundus photography or ultra wide field imaging alone. So for me, I think the take home is do both if you have both, but I think it's very important that you do dilate patients. The next standard of care document that kind of addresses this question, do we need to dilate patients when we're doing a diabetic eye exam, comes from the American Academy of Ophthalmology and their preferred practice patterns, which was just updated in 2024. And they said annual eye exams optimize prompt detection of diabetic retinopathy. They're recommending patients with type 2 diabetes. And look how it says dilated eye exam. Should have an annual dilated eye exam to detect the onset of diabetic retinopathy. This is quote from the standard of care document. They also go on to say a dilated pupil is preferred to ensure optimal examination of the retina because you may misclassify, and there's some data to support that. They go on to say slit lamp biomicroscopy is the recommended method to evaluate retinopathy in the posterior pole and mid-peripheral retina using a 90 diopter or 78 diopter lens. Examination of the peripheral retina is best performed using indirect ophthalmoscopy or slit lamp biomicroscopy. They also mentioned in this standard of care document that studies have found a positive association between participating in this is retinal imaging screening program. So not a patient that has come into your examination for like a diabetic eye exam in your chair in your practice, but this is doing like screening outside programs outside the optometric office, and highlighting that certainly that does have value, especially in areas where access to care is limited. And they kind of just go on to say those screening programs should follow established guidelines, given the known gap in accessibility of direct eye exam screening. Retinal imaging screening programs may help increase chances that at-risk individuals will be promptly referred for detailed evaluation and management. So I think what they're highlighting here in this statement is saying that retinal imaging is very important for screening in areas of low or limited access to care. It should not be a replacement of your dilated eye exam when you have a patient in your practice and in your exam. I've also pulled some of these statements and tables from the preferred practice pattern. And you can see highlighted there where it says dilated. And they're even saying when we're staging diabetic retinopathy, it says findings observable upon dilated ophthalmoscopy. So I think you could get yourself into trouble if you're not dilating, you're staging, and say you undergraded the stage of diabetic retinopathy. Someone could come back here and argue and say, well, you didn't properly dilate the patient, which is what the standards are based upon. And last but not least, the American Diabetes Association also has some guidelines with regards to the eye examination. And they also put like verbatim here, dilated comprehensive eye exam. So I think the take home here is you have at least like 3 very strong entities publishing standard of care documents that indicate that you should dilate patients on an annual basis with diabetes when you're doing your examinations. See how much time I have left. How do you view the role of AREDS2 vitamins in patients with GA? There's an interesting dynamic in the research. AREDS2 use was not tracked in the complement inhibitor trials, though some studies have shown that AREDS2 alone reduces GA progression, and others report that the zinc content can worsen geographic atrophy in some patients. How do you navigate this intersection? First and foremost, Brenda, thank you for that excellent question. I'm not familiar with what the zinc study that you're referring to, how it may worsen geographic atrophy, but I do have some comments regarding Yeah, this publication that looked at AREDS2 benefits in patients with geographic atrophy and the various subgroups, saying whether it's center involved versus non-center involved. And so what they found in this particular study is that AREDS2 supplementation is beneficial in patients with non-central geographic atrophy. It reduced the progression towards the center of the fovea. It also slowed GA progression in general, like enlargement. So definitely I'm recommending AREDS2 in patients that have geographic atrophy and useful vision. I mean, like if both eyes were like count fingers or something, in which case then maybe that's not appropriate. And if there's concerns about zinc, I know there are options of getting AREDS2 formulations with lower zinc concentrations, say 40 milligrams or 25 milligrams instead of the 80 milligram value. That's something I generally recommend already because I don't like the higher dose of zinc. And I think the AREDS2 study supported that we can lower the zinc and still have the beneficial effects for patients. So AREDS2, I think, definitely a strong consideration in patients with GA. It's probably most helpful in patients that have non-central geographic atrophy. And to, I think, kind of add some other things on top of there that I would consider when patients have maybe, or so let's say a patient has like really early geographic atrophy, right? And you're trying to say, what can I do for this patient? Certainly, I would refer to Retina for consideration of complement inhibition therapy, but like, let's say that patient hasn't yet shown progression, or the lesion's not quite large enough for complement inhibition therapy to match those individuals that were enrolled in the FDA, like phase 3 clinical trials. So you're trying to look for something else. How can we slow the progression of atrophy, or how can we prevent the development of geographic atrophy in patients that we know are like high risk intermediate stage? And so I think we now have several options. We said AREDS2 is definitely an important consideration in those patients. And we now have photobiomodulation available as an option to not only reduce the onset of geographic atrophy or the development of geographic atrophy, but also potentially improve the vision in patients with intermediate stage AMD. And so photobiomodulation was FDA approved in 2024. And some of the, it's delivered in 9 sessions over 3 to 5 weeks, repeated every 4 months for a total of 2 years. And this was the LightSight 3 study. This was a 2-year duration study that got this photobiomodulation FDA approved. And we can see there was a mean difference between sham versus the treatment groups of approximately 4 to 5 letters. So about 1 line on like your ETDRS VA chart. But what I found very interesting is, and this is like post hoc analysis, so this wasn't like a primary endpoint of the study, just to put a disclaimer on that, is that they found that photobiomodulation here at month 4 decreased the incidence of new onset geographic atrophy. So as you can see, the sham group, about 1 in 4 developed geographic atrophy over 2 years, which is pretty terrifying, versus the photobiomodulation group, it was only about 7%. So we can help patients that have intermediate stage AMD that are at high risk. Like let's say they have a lot of risk factors for progression, like large soft drusen, reticular pseudodrusen, hyperreflective foci on OCT, right? We know, or they're exudative in the fellow eye, right? So these are all like high risk things that we know they're likely to progress. Certainly AREDS2 photobiomodulation is key. Once they develop pretty significant geographic atrophy, I think then kicks in like complement inhibition therapies in order to slow the progression of that geographic atrophy into the center of the fovea there. And let me see if I have one more short and sweet one I can answer before we go. There was a question that came in, not really related to retina, but I think an interesting question. I love neuro as well. There was a patient with unremarkable, like normal examination, but had a sluggish pupil reaction, no prior surgery, no trauma, APD, no symptoms. What sort of workup would you do? So assuming that this is bilateral, sluggish, direct pupil responses, I would then check the near or accommodative response. If the accommodative response is intact, it's telling you the muscle is working well, right? It's then we would call it light near dissociation. When I have patients with light near dissociation, I try to determine what could have caused that. So dorsal midbrain syndrome could potentially cause that. Those patients often have like mid-dilated pupils as well as lid retraction and upgaze palsy. Syphilis could also cause that, right? So like Argyle-Robertson pupils are typically like smaller meiotic pupils that don't react well to light, but do respond very briskly to near. It could be a patient that had like bilateral tonic pupil would be another consideration, or other sort of like neurodegenerative diseases. But my workup would be investigating for diabetes and investigating for syphilis. So like an A1C, glucose, and like an RPR that reflexes to FTABS. And so that's all the time we have here for this sponsored hot seat session by Astellas. Thank you, Astellas, so much for allowing us to have this educational discussion here and all these excellent questions that rolled in. Thank you, everyone, for who put in questions. We'll get to some of these additional questions in the next hot seat session. We'll see you guys soon.